today about basically methods that we initially developed as part of a disease control priorities project, which is in its third edition. And the motivation was to try to actually address some limitations of cost effectiveness and to look at specifically two items that many policymakers at different levels are interested in, which are distributions and equity and financial risk protection and poverty reduction. And what I'll do here is that I'll basically yes. So what I want to do in this time is to have expose with a lens why we have motivation to do this and why we look at these outcomes, and then but there's many aspects of it, and then look into details about and explain what we did with ECEAs, as we call it, apply it to vaccines, and then have a few remarks about how that may be used for child health priority setting. So the first thing what I want to talk briefly about is that, and most of you are very familiar with the SDG framework, and we've had a very substantial discourse post 2015 moving from NGGs to SDGs about the discourse on poverty. I mean, SDG 1, the Sustainable Development Goal 1, is basically states specifically to eradicate extreme poverty in all its forms everywhere by 2030. In the meantime, I guess with a change of leadership at the World Bank, Jim Kim, really, emphasized a lot of, when you hear his speeches, the dual objectives of eradicating extreme poverty, which is, something that the World Bank actually, constantly estimates with specific indicators, as well as boosting shared prosperity, and, to lift basically the situation of the bottom 40% of populations. There's good reasons to be hopeful if you look at, and these are World Bank estimates over the last 25 years. There's good reasons to be hopeful if you look at the number of people living under $1.90 per day over the last 25 years, from about 2 billion in the 1990s to less than 1 billion today. And today we have less than 10% of the world population that is living under that defined poverty line. In that sense, moving forward, and these are projections, there's a number of very aspirational objectives that have been put forward. In the case of a scenario with a 4% income growth, the projection would set that, in 2030, about 3% of the world population would be living under that poverty line. Yet, this graph here displays the vast heterogeneity among continents, and Sub-Saharan Africa still concentrated about 15% of its population under the poverty line. In health, I guess, we have our own SDG, which within it, SDG 3, has a lot of indicators. But a broad theme, which the WHO has been very instrumental in relaying, is the universal health coverage. And thinking about poverty, the specific link to poverty is the financial risk protection. The goal, the SDG 3 for health, stipulates to achieve UHC, including financial risk protection for all. So now, what's, if we believe, I mean, there's many ways to think about this, but if we believe that, as a development community, whether we work only on the health sector or, many sectors, education and so on, the question, or the big question we should ask, such as perhaps, for MDG 4, MDG 5, we were specifically, trying to articulate policies about reducing under 5 mortality to some specific, thresholds and so on, is, how to achieve, eradication of extreme poverty defined by some indicators by 2030. So now yet the message becomes much less clear, and, there's lots of articulations about, what people might think are requirements, investing in human development, education, health, and so on, perhaps having more development of private markets, and things like safety nets and so on. But what often we find is, and whether it's in health or across sectors, is that there's actually quite a lack of specific propositions in terms of how much it costs and what's the impact in terms of poverty reduction. So I guess, in that line, and what I was trying to say here is that to expose that perhaps, goals of, equity and poverty reduction might be important benchmarks or, thresholds over which we might want to think about our investments in health. Now, in the same way, actually, this is not really orthogonal to, for instance, what WHO, considers, as objectives of health systems in some earlier frameworks that the WHO developed, or even within the universal health coverage, where improving health, but also the distribution of health in population, as well as basically improving the fairness of financing contributions toward health, were considered as important objectives of health systems and the health sector. So what basically we try to do in this work on extended cost effectiveness is to reflect on what might be useful in terms of economic evaluation that might be useful for health policy assessment. In other words, trying to think about moving from the cost per quality figure of merit, which often uses or examines a very specific technical intervention. I list the ART here as an example, and to think about the broader things that are important in priority setting for policy in the health sector in particular. Sort of reflecting of also what broader development agendas, such as the one I was just putting together with the SDGs, as well as perhaps what might be objectives of health systems. And on the one hand, it is clear that policy interventions are actually basically grouped in terms of packages or delivered with some specific platforms. In immunization, you have a broader EPI program. It's not only about measles vaccine, it's about measles, DPT, and so on. And you can also have supplementary immunization campaigns when you go out in the field and you deliver things. So that's one thing, which is, the delivery platforms, or you can think of a surgery platform in a hospital that doesn't only do eye surgery, but a bunch of different things. Then at a high level, they are policy instruments, which are actually the things that really, and we just had a small discussion about the Gavi pricing, over tier pricing. They are actually, some financing policies or policy instruments that actually drive, where you put the investments into platforms into which you put specific interventions. Things like public finance, which is the easiest way to think about these things, which we derive in a number of countries, health insurance, but also things like legislation, perhaps financial incentives like conditional cash transfers, or taxation of specific, harmful products like tobacco. The other thing is that clearly there are a number of, criteria as we, have we gone over in the previous presentations that are important, including, the dimensions of distributions and medical impoverishment related to basically healthcare spending by individuals. So I guess if we think about, what might be our policy objective, to recast in terms of equity and financial risk protection or poverty reduction purchase, if we speak like economists, what we might be interested in is what would be cost-effective investments in terms of financial risk protection, as well as equity. In other words, the sort of analysis task might be that for a given cost of, or if we take a bundle of policies, we might want to compare them in terms of the cost they have, as well as what is the amount of financial risk protection or poverty reduction they're buying, and also how, in some ways, the benefits here, I'm mentioning health benefits, might be distributed into the different population subgroups we might be interested in. And in other words, trying to think about estimating number of poverty cases averted per dollar spent, and how much of perhaps mortality averted would be for specific, marginalized or vulnerable groups in population. So what we basically do in the ECEA work is to focus on two dimensions when we do health policy assessment. And one is to look at, the health outcomes, mostly focusing on, I would say hard outcomes, not, constructed metrics like QALYs or DALYs necessarily, but that can be applied. And trying to basically look at distinct strata of populations that are of interest. Obviously, socioeconomic status, income quintiles are a very substantial, area of interest. But one can think for especially for planning purposes, that subnational data in terms of, specific districts, region might be actually relevant from a planning purpose. The other aspect is trying to quantify what is the medical impoverishment averted by, enactment of specific policies. And, how if I basically invest in a package of vaccines, how not only I, basically avert more mortality and morbidity, but I might as well, prevent the healthcare spending that are tied to the fact or to the onset of these diseases that the vaccines would be prevented. So basically, and I'll go into a very concrete example shortly, what we do is that we take, a specific, policy, so say the public finance for vaccine, and then we basically examine three kinds of things. The first is, the health gains, and say, for instance, the deaths averted by, by the vaccination. That would be one. And then I guess the thing that we do, which is distinct from a traditional cost-effectiveness analysis, is that we shift the gear, even though these investments would be made by, say, a government or a donor, and then we shift the gear to the perspective of households. In other words, we are examining what is the amount of out-of-pocket payments related to, say, direct medical spending at the point of care, as well as, transport costs, and trying increasingly to think about, this is different and distinct than out-of-pocket cost, but what might be indirect cost in terms of, time losses and wages that are basically, tied to the onset of specific diseases. And then in some ways, given the magnitude that, or the financial catastrophes or consequences that are incurred by households, trying to basically understand how that is significant or not compared to people's income. In some words, trying to account for the fact that if you spend $100 and you have an income of $1,000, you will be much more impacted than if you had an income of $100,000, for instance. And that is trying to quantify what is the financial risk protection benefits that are basically, obtained through, specific policies. In other words, trying to scale the spending or financial consequences with household, what is the sort of purchasing power that they might have. There's different ways to do that, including actually estimating insurance risk premiums, which we had just a discussion about insurance, as well as also relying on a number of commonly used metrics as poverty, impoverishment cases, or catastrophic health spending, which the World Health Organization, for instance, routinely measures them. And then the last thing is disaggregating things by different socioeconomic groups, like 5 income quintiles, for instance. So now digging into basically what we do with those, I'll just take the example of a study we did on rotavirus vaccine, a model where we basically looked and applied the sort of free bundle framework that I was just showing previously. And to 2 countries, India and Ethiopia, looking at 1 million birth cohorts in each country, and you'll see 3 of these graphs coming up, corresponding to these 3 bundles, these 3 boxes, and basically comparing outcome, on the y-axis, and then the income quintile from poorest to richest. So, and what we assumed in this case, to be clear, a flat, vaccination coverage, so we could understand where the impact would be coming from. And what we see is that looking at the health benefits, we see that there's a significant propor gradient among, benefiting to the poorest socioeconomic groups, which is a resultant of the fact that, disease burden is significantly higher among the poorest socioeconomic groups. So that's number 1. Number 2 is to think about the distribution of out-of-pocket, costs. Same thing, outcome, which here is expenditures averted in thousands of dollars, which is including only the direct medical costs to inpatient care for severe hospitalizations. That would be averted by vaccination as well as the outpatient care. Again, what you see is a distribution here. And in this case, you see a slightly increasing gradient, which is actually a reflection of not only the fact that, people in higher quintiles would spend a little bit more, which is certainly the case more in India, for instance, but really the fact that actually as most of you know, the healthcare utilization gradient is highly skewed towards the richest income group. For instance, the likelihood of seeking care, if I recall exactly, in Ethiopia is perhaps 3 times higher among the richest than in the poorest quintile. So that is more perhaps a, not so progressive sort of outcome. Now yet, if you basically think about sort of, even though that's not exactly what the mathematics is behind that, but scaling that with people's income. So in other words, basically dividing the numbers that you've seen on the previous slide by, people's ability to pay. So looking at some financial risk protection with using some, insurance risk premium, estimates using some utility function. What we find is that the financial risk protection is highly beneficial to the poorest socio-economic groups. As I said in the summary box, there's basically less disposable income, even though there are other things playing out. One last, aspect of this is that what one can do, coming back to, the geography. I mean, a number of these information, in fact, from a sort of planning purpose, a lot of countries can be either federal or have, and where some federal governments have actually a lot of autonomy and so on. We can basically do exactly the same thing to the extent that the data is available to think about what might be, in this case, an incremental cost effectiveness for malaria vaccine in, the provinces in Zambia. And what you can find if you still want to use a traditional cost effectiveness framework is that, coming back to the income quintile, you might have, where this is the same, the cost effectiveness ratio, and, the income quintile from poorest to richest, you can find that you have significantly lower. So you actually, in this case, both perhaps equitable, but actually more cost effective or efficient if you were going to, provide the vaccines and targeting first these subgroups. So let me just, wrap up with just a few comments of how this might be, relevant for priority setting in vaccines and in global health in general. So I guess the first thing is that, and this is an example, it's the rotavirus example in Ethiopia. So where you have $1 million spent, say that can be your part of your budget, and that can also be coming from Gavi, which I'll just say up front, these are 3 scenarios that actually correspond to different kinds of subsidies, graduation level, etc. from Gavi. And what you have is basically the number of deaths averted related to rotavirus, and then financial risk protection. So the higher the better, the more on the right the better, per socioeconomic group. So 1 is the poorest quintile, 5 is, the richest quintile. And what you have, that's public finance for $1 million spent. So it's basically sort of efficiency by quintile in 2 dimensions, for health economists. And what you see here is that there is this very substantial gradient with the impact of Gavi pricing, which is that if the vaccine is cheaper, you just get a lot more financial risk protection and, deaths averted. Now, what you can point here is that, and using these, using ECEA, is that you can directly point here to progressive prioritization, which is wherever you are on these pricing scenarios, you can clearly flag, what might be the benefits among, the poor socioeconomic groups in terms of your returns on your dollars spent, in terms of poverty cases averted and deaths averted. And in that case, actually, you can, see that the most efficient would be the investment in this quintile. And you might, accordingly, sequence your planning, perhaps prioritizing the worst off, the poor socioeconomic group, but also perhaps the worst off region in that sense. So trying to flag out what you would perhaps recommend as a progressive prioritization. The second thing is that you can, so this is a similar sort of graph where you have, a budget, so an incremental expenditure, and basically, health gains can be deaths averted, other metrics you would like, and then, poverty reduction benefits, poverty cases averted, etc. And what you can do with this is basically think about mapping out, and this is not, data, this is just, a range of vaccines where, perhaps some of the positioning is more informed than others from my side. But what you can do is think about, obviously you can do a quantile analysis on the 3rd dimension as well, but you can think about how each vaccine that are in a basic package would be positioned. So for instance, things like measles vaccine are, highly cost effective. So for a given increment of dollars spent, you have basically a lot of, deaths averted. Maybe something like dengue or HPV, Hep B, which incur cancer with very, expensive treatment, might actually, bring a lot of financial risk protection or poverty reduction benefits. And I guess the point here is that having that, enables to certainly take different criteria, coming back to a sort of, I guess, of the theme of the conference as well as some of the preceding presentations, to basically design a basic vaccine package or a health benefits package. Doesn't have necessarily to be thought of vaccines. And I would argue that, clearly what we've basically been doing in the cost per quality, thinking is really focusing on the right-hand side, which is what are the, highest returns in terms of, quality gained, dollars averted per dollar spent. Now, we haven't spent much time on the upper side, which is what is the largest returns on poverty reduction. And it's kind of paradoxical in the sense that, at least I try to expose the, sort of momentum given by SDG 1, and also the fact that, if you talk to policymakers, ministries of finance in many low middle income countries, they're very interested in knowing, how investing in health is going to be better for economic development. And they do watch very scrupulously their poverty rates. And the other thing is that I would say that, interestingly thinking, backwards, when you look at the, not that it is the best example, but the creation of, health insurance in Europe in 1945, whether it's, in the UK, which is explicitly stated in the NHS, the National Health Service status, but, France, Germany, there was an explicit recognition that providing health, and developing health systems and health insurance was really to address money worries. And it was about things beyond health per se, but, ensuring a welfare state, and that, health systems would be integrated with a certain welfare vision. And to end up, I would say that, what's, I think, important, and perhaps to circling back to, if we believe that SDG 1 is a very, important lens over which we think about development, what perhaps is more important is to really think, and I think, a number of presentations from JP to Raymond's really try to highlight that, is that perhaps what's most important is to think about, not preaching to the converted that we are in terms of the impact of vaccines. And the people that really are important are people who do intersectoral calls, people that are basically not managing the health sector, and that perhaps we need to speak outside the health sector for doing priority setting, which means to talk to ministries of finance, to talk to prime minister's offices, who often have social protection units where they look at investments in education, investments in agriculture, and so on. And then in that sense, actually, with that kind of framework, what we can do is we can think about, for instance, casting our outcomes in terms of poverty cases or impoverishment, poverty reduction benefits per budget spent, and definitely starting to make the case. Obviously, I just made the health higher here, but so that you're happy. Not that I change that when I speak to a Ministry of Education, but basically, then, really making the case that for economic development and poverty reduction, actually, the intersectoral comparison is beneficial to health, and that might convince a Ministry of Finance or a Prime Minister who has a specific agenda in a low middle income country. Thank you very much.